Good morning, everybody. This is Senator Martine LaRocque, the Vice Chair of the Senate Health and Welfare Committee. Chair Lyons is busy this morning at a conference committee, so I will be kicking off the meeting. We are going to start today with a bill that we haven't yet taken a close look at, H237, which is an act relating to prescribing by doctoral level psychologists, H237. And we're going to start with receiving some testimony from Dr. Rick Barnett. We would ask that Dr. Barnett please take the very comfortable chair again. Thank you, Dr. Barnett.
It's not comfortable. No. All right. So for the record, my name is Dr. Rick Barnett, licensed psychologist, doctor, licensed alcohol and drug counselor. I'm the chair for the Vermont Psychological Association Legislative Committee. And regarding H237, which passed unanimously out of the House and is now here in Senate Health and Welfare, grateful for committee members for taking up this bill and hopefully getting it through. It's something that the Vermont Psychological Association, along with the American Psychological Association, have been working on for many, many years, but specifically here in Vermont as it relates to mental health access, mental health services access in terms of shortages of psychiatrists, psychiatric nurse practitioners, and really wanting to serve Vermonters in the best and most effective ways possible with quality mental health care. Something that's been going on across the country for years now is doctoral level psychologists getting the authority to prescribe and de-prescribe psychiatric medications using talk therapy as their primary modality of working with patients, but being able to work effectively with collaborating providers and patients to figure out their medications to see if they're actually working for them or if they could be helpful. So that's the genesis of this particular bill. Again, it's been going on now for 9 years here in Vermont, trying to get this bill passed. So it's been a long haul. And just the latest iteration, I think the reason why it's gotten so far this time is because the Office of Professional Regulation took this issue very seriously back 3.5 years ago. And they did their inaugural Sunrise review process where they looked at scope of practice issues, and the Vermont Psychological Association applied for this Sunrise review. They did a thorough vetting of all the elements of what's involved in this scope of practice change. They heard testimony from proponents and opponents, really did a deep dive, and they came out with their report in January of 2025. So it just came out. And you'll hear testimony from the Office of Professional Regulation on this particular bill this morning. But their report was really solid, looking at all the pros and cons associated with this. This isn't a quick fix. This is not a cure-all. This is just a small change that we can make to help a few more Vermonters get access to quality healthcare. It's not supposed to change the world. Also, the sky isn't going to fall if psychologists get the authority to prescribe. The training is robust, and that's one of the things that's changed in this particular version of the bill. Again, this bill has seen 9 versions here in the state of Vermont. This latest version is extremely robust. It adds 18 months, currently 14 months, but we're asking for a change to 18 months of clinical rotations in 5 different medical disciplines. That's extensive. That was not in any of the previous bills. That's in response to the opponent's concern that the training wasn't robust enough. So there's other modifications I think that the Office of Professional Regulation was comfortable with in terms of safety and efficacy of the training, and hopefully being able to support this getting across the finish line. So the other things that I think are important to note in this particular bill are some age restrictions in prescribing and the collaborating provider stipulation, so that prescribing psychologists would need to have a collaborating provider. Currently in the bill, it says psychiatrist only. I happen to wish that it wasn't restricted to psychiatrists, primarily because there is a limit of psychiatrists, and also psychiatrists have historically opposed this legislation, so it might be more contentious to try to get a collaborating psychiatrist. Thankfully, the committee has received testimony written from several psychiatrists here in the state of Vermont who do support this bill. So even if it was restricted to psychiatrists as being collaborating providers, we believe that we still will be able to find friendly psychiatrists to help us collaborate in this endeavor. But if we could expand it to psychiatric nurse practitioners, some of whom also support this bill. They are very qualified prescribers and collaborators, as well as primary care physicians who, as we know, primary care physicians prescribe 70% of the psychiatric medications prescribed in the state and across the country. So the fact that they wouldn't be eligible as collaborating providers is kind of confusing to me, but I understand concessions need to be made to get this bill across the finish line. So I'm open to any questions. Hopefully I covered the basis of the point of this bill. It's a solid bill. There's been a lot of contention over the years, understandably, but I think we've done a good job and really be thorough in trying to produce a product that could be good for Vermonters.
Thank you, Dr. Barnett. It's really appreciated. I really appreciate the idea of using all the tools that we have in our toolbox to help folks who need it the most. So I appreciate this as you know, something that we're going to take up and look at closely. It's really thankful for the work for sure. Does anyone, hello, Senator. Does anyone have any questions for Dr. Barnett?
Actually, I don't have a question, but a lot of this, I mean, like the S-36, I'm not sure if you ever know much about S-36.
I saw it earlier in the session. Yeah.
Oh, I think we extended it out with a couple, the House did a couple amendments to it, a few amendments to the wording, that's correct.
Medicaid coverage for substance use treatment.
And mental health up to 100, whatever days possible necessary, not 14 days. So that's the whole bit.
That's great. Yeah.
Toolbox, yeah.
That is one of the tools.
Yeah, exactly. Thank you. Thank you, Senator. Yes, Senator Douglas.
A very, very small question. You mentioned the psychologists do primarily talk therapy.
Yeah.
Do psychiatrists also do primarily talk therapy as well?
No.
No.
Some legacy, some old school psychiatrists who were trained a long time ago were absolutely trained in talk therapy as their primary modality. But with the psychopharmacological revolution in the 70s and 80s, a lot of new psychiatrists in the last 2 decades have really been trained in a purely biomedical model. Of course, they get some training in talk therapy, but really it's all about prescribing. So their psychopharmacological knowledge is exceptional. But they don't primarily, I think there's some data out there, cite studies that show, I think about 10 to 20% of psychiatrists still do some form of talk therapy, but most of it is med management.
Medication.
Yes.
That's consistent with my experience. Would you, do you think that if this would have passed, would put more meds out there for clients, or do you think it would be the same level of the responsibility of the psychologist going to goals that would continue that talk therapy? Because I'm a big believer that psychiatric medications are gifts to humanity, but at the same time, we shouldn't overprescribe, and I think that's the case for every medication. So yeah.
I believe that that's the part of the motivation, the inspiration for this bill is we don't want that. In fact, as it relates to the training, one of the resistances we had to making the training more robust, even though we understand from a safety and efficacy standpoint that that's important, prescribing psychologists aren't attempting to be trained as just another medical provider, just another junior psychiatrist type of role. Our goal is to retain our identity as talk therapists, and primarily using that as our modality. And one of our taglines typically is that, I don't know if it works very well, but the power to prescribe or the responsibility to prescribe is the responsibility or power to de-prescribe. And having a model where we're trained to sit with people for 45 minutes and do talk therapy week after week, as opposed to being trained to do med management in 10 or 15 minutes with every 3 to 6 months, meeting with patients, 30 patients a day, just managing their meds. It's a very different model. We're not looking to recreate the psychiatric model. We're looking to retain our identity as prescribing psychologists, doing talk therapy and being able to assist so that that patient doesn't have to go see a psychiatrist, to go see their primary care physician, that we have a collaborating agreement in this bill that we can do a quick check with our collaborating provider and we can handle that in our office. And we get to see the patient for 45 minutes and we see them completely. And there is data out there showing that prescribing psychologists in New Mexico and Louisiana who've been doing this for 25 years retain their identity as psychologists. They're not just being med management folks. They're slow to be taught there. So I think that's a valid concern. That's been one of the arguments, even within psychology.
Mhm.
There are some psychologists within psychology who don't support this because they're concerned that this is just going to turn psychology into psychiatry. When in fact, what we've seen so far with the 7 states that have passed this scope change already, that we're not becoming psychiatrists. We're retaining our identity as psychologists, but we have the ability to prescribe.
Interesting. Do you think that there's any, it's kind of spitballing, do you think there are any, guardrails or anything that you put onto this to kind of address some of those concerns? Because I love everything that you're doing and everything you're saying about talk therapy. I think, in my opinion, I think it's probably more effective than medication in a lot of cases, especially with trauma.
Mhm.
So do you think that there are any compromises to address those concerns?
I think the guardrails are embedded within our code of ethics as psychologists. So the American Psychological Association has a very robust code of ethics. And what they've done with prescribing psychologists is they've expanded their code of ethics to prescribing psychologists have specific code of ethics so that that kind of thing doesn't happen, that we have to fall within certain guidelines, ethical forms of conduct. So we're not like spilling over into becoming the next generation of psychologists.
Thank you.
Yes.
Those are really good questions, Senator Douglas. Thank you for asking those. Yeah, I just, this just makes me think that, it all just fits nicely in with the reform that we're doing this year as well, just expanding access to folks across the state of Vermont. So again, just much appreciation. Any Senator Cummings, did you have any questions? No? Okay, great. Well, Dr. Barnett, thank you very much.
Thank you very much.
I really appreciate you coming in. The next witness is Stephanie Winters, the Deputy Executive Director of the Vermont Medical Society. Good morning.
Good morning.
Do you? You do, that's right. I complimented you.
Oh, I just got it. Can you 32 grab
That's where I
chair?
got.
Oh, small world. Good morning.
Good morning.
Stephanie Winters. I grew up in East Montpelier and went to U32, so small world.
There you go.
I am the Deputy Director of the Vermont Medical Society, and I also am the Executive Director of the Vermont Psychiatric Association. As Dr. Barnett said, this has been a long road. I represent over 3,000 physicians from across specialties and across the state. So thank you for allowing me to testify on H237. As background, we have been involved in a number of legislative forays and also the Sunrise review process with the Office of Professional Regulation. And I did submit what we submitted to OPR in 2019, I think, maybe not 2019. Anyway, 2020-ish. And you can have that in your files. While the discussions have come a long way, we were happy that House Healthcare took this up, took testimony that the Office of Professional Regulation has listened to our concerns. We still have concerns regarding the actual benefit of adding more prescribers in Vermont to the healthcare system versus increasing the much needed mental health services that psychologists currently offer and have expertise in. We've heard of this as being touted as an access and a workforce initiative, and that is concerning to us because from what we have seen from other states, there's no evidence that authorizing psychologists to prescribe medications will actually increase access to needed mental health services in Vermont. In other states with prescriptive authority, few psychologists have sought such authority and they've not moved to underserved areas of those states. In fact, in 6 states that allow psychologists to prescribe, there are just over 200 licensed to do so. And I say 6 because the 7th just passed, so I don't really have numbers from that. I started to draft my own chart, but then found a very illustrative infographic from the Society of Clinical Psychology, which mirrored our calculations. And that's in my written testimony. There's also a link. You can click on it and make the chart bigger, but it shows the states that have passed this, their, how many licensed psychologists they have, how many actually have prescriptive authority, and compare that to the population. So it's just an interesting thing. So if Vermont followed these ratios of practitioners to population, we could expect to see 1 to 5 prescribing psychologists in 5 to 10 years. And given that, there are already a breadth of prescribers who receive extensive medical and psychoactive prescribing training. And there's another chart that outlines how many prescribing people there are in the states that have passed this, from physicians to physician assistants to APRNs, and then psychologists. And you'll notice that the pie chart is very small for the psychologists. And some of these states have been decades where they have passed this. Of note, the Society of Clinical Psychology posted the article, which you can click on and read, titled "The Prescribing Psychology Workforce, Enough to Matter, Worth the Cost." And it summarizes that given the small number of prescribing psychologists and the high costs associated with advocating, it's reasonable to question whether the movement is a worthwhile investment. Moreover, relatively small minorities of psychologists have sought to prescribe where they've been able to. From a workforce perspective, it is not clear that psychologist prescribing will ever achieve the kind of momentum that could make a meaningful difference in addressing the nation's pharmacological mental health needs. The numbers to date plainly do not support the ideas that prescribing psychologists play a major role in expanding access to psychopharmacological care, nor will they in the future. Their solution is collaborative care. Psychologists are well equipped to work alongside psychologists and other physicians, nurse practitioners, and PAs in an interdisciplinary team. By leveraging their strengths in psychological assessment, psychotherapy, consultation, and research, psychologists are well positioned to contribute to comprehensive patient care that addresses needs. We strongly support this recommendation and elaborate below on methods to expand access to collaborative care in Vermont. Access to mental health and psychiatric services is a legitimate concern in Vermont. The good news is there are evidence-based answers that address access to care while maintaining physician or advanced practice professional prescribing. Many of these efforts are already happening in Vermont in a limited way, and expanding them would be a significant benefit to Vermonters. These include the Blueprint for Health and the Dulce expansion pilot that assists practices in addressing mental health, substance use disorder, and social determinants of health needs. That's going to end this year, absent legislative action. Increasing retention and recruitment of psychiatrists through loan repayment programs, reimbursing psychiatrists and primary care providers for consulting with each other directly, increasing access for primary care practices to the collaborative care model, which is what I discussed earlier. And a great example of this is the Vermont Consultation and Psychiatry Access Program, formerly known as the Vermont Child Psychiatry Access Program. And I've outlined other areas as well in my testimony. The bill as passed the House does include some safeguards with additional standardized training, including completion of a postdoctoral training program in psychopharmacology. We recommend or would ask that the bill include language requiring OPR to engage in rulemaking to establish specific requirements for curriculum design. And I have suggested language under the rulemaking section of the bill that would add the minimum requirements for curriculum of a designated postdoctoral psychopharmacology program. I think some of our psychiatrists received an email on the Idaho State University psychopharmacology program and were impressed with its curriculum. We have reviewed OPR's suggested language, which you haven't heard about yet, but will, on clinical rotations, and agree with an 18-month clinical rotation to include specific specialties such as psychiatry, geriatrics, family medicine or internal medicine, emergency medicine, neurology. And we believe if this moves forward, this bill, it is critical to have these to provide some valuable medical knowledge and skills. We also support if this bill were to move forward, having a collaborative practice agreement with an MD or DO who specializes in psychiatry. And we feel strongly that this is to be a psychiatrist, because having a psychiatrist specifically is crucial because they possess the specialized knowledge and training to diagnose and treat mental health conditions with expertise in prescribed nootropics. I'll end with just saying that psychologists are experts and important in mental health interventions and are highly valued members of the healthcare community. While the bill does incorporate safeguards, we continue to be concerned about diverting important time and resources away from professionals doing what we need more of, which is not prescribing. We also are concerned that we are going into this for the wrong reason. This is not a solve for increasing access to mental health care. And as I mentioned, we do already have important programs that are being cut, partially funded, or not fully utilized to support patients.
Any questions for Deputy Executive Director Winters?
So formal.
She nailed it.
Yeah.
Can you speak to us about psychiatrists, telehealth, relationship with telehealth and what they're allowed to use?
Yeah, so telehealth is an interesting because it's by state law and what is allowed. And so if they have a patient who is in Florida, it goes based on Florida state laws. It depends on where the patient is.
Yeah. Okay. Yes, Senator Douglas.
Thank you, Madam Vice Chair. So on your first page of testimony, you say there is no evidence that authorizing psychologists to prescribe medications will increase access to needed mental health services. If that evidence existed, what do you think that would look like? What sort of form of that evidence take?
Well, I think first and foremost, it would be more access for patients. I think it would be more collaboration between. We need this in our entire health system, more collaboration between members of interdisciplinary teams. I don't necessarily think it's access to more medication. As Dr. Barnett said, it's not necessarily that we need more medication in our system. It's how to actually provide the services that patients need that may not include psychotropics or medication. But I think access is the key, and we have not seen that in the other states. So that, I guess, access would be first and foremost.
Right. How many practicing licensed, maybe this will be our question, but psychiatrists currently prescribing medication are on?
Currently prescribing medication? Well, OPR does. So psychiatrists, OPR does not regulate. Psychiatrists are under the Board of Medical Practice. We have sort of a split regulatory model. So there are probably 200 licensed psychiatrists, and I can get the specific number for you. And I believe there are 316 doctoral level psychologists licensed in the state, something like that. And there's more that aren't doctoral level.
Right. Because I see if somebody's going to their PCP and they're having a conversation with mental health issues that they're experiencing, their PCP as a doctor might think, well, this issue might require medication. So instead of referring this person to a psychologist that might be 20 minutes away, because I think they might need medication, I'm going to send them to a psychiatrist an hour away. So I do see there to be some sort of common sense or logic to the argument of having more access. Because if you think you're going to need medication, you're going to go to the hour away psychiatrist from the start. You're not going to want to see the psychologist just because they're closer. Because if you think you're going to need medication, you're going to rather just see the psychiatrist, which, as Dr. Barnett, said earlier, they're kind of shifting away from the talk therapy. So you might go to a psychiatrist anticipating that you're going to get a lot of talk therapy with the potential getting meds on top of that. And then maybe, unfortunately, when we get the meds, when you're looking for both pieces.
Yeah, and I think your scenario has a lot of caveats. What's the complexity of the situation? If it's something that the primary care thinks that they can handle and they think medication is needed, they will most likely prescribe that medication.
Mhm.
That is where the collaborative care model would come in. So in CPAP, for example, and CPAP, not the breathing machine, but the Child Psychiatry Access Program, in the primary care setting, they have a patient in the office. They're not quite sure how to handle it, but instead of referring out, they make a phone call. They have a consultation with a psychiatrist, and the psychiatrist says, do this, or let's make an appropriate referral to a higher acuity of need. So in that scenario, you have two very highly medically trained professionals treating this patient in one setting. So that is the ideal. So you don't have to send that patient anywhere. You don't have to refer them out anywhere. If talk therapy is what you're looking for, then that's great. But there are already that level, if they're already in their primary care setting, there are already avenues to keep them right there in their medical home.
Thank you, Senator, and thank you, Stephanie. That's very helpful. Next up is Jen Hollis from OPR, General Counsel.
Hi there.
Hello, good morning.
Thanks for having me today.
Thank you for coming in.
For the record, Jennifer Colin, General Counsel for the Office of Professional Regulation.
Just get situated here.
Well, this has been a long effort, and the Office of Professional Regulation has done a lot of study of this issue. As you know, our primary focus is always public protection. And so we think that H237 strikes a really good balance of having measures in place to ensure public protection with psychologists prescribing in the state of Vermont. We do have some proposed language, which is in our written testimony. I think we may have submitted that this morning. So you have access to that. So OPR did complete a Sunrise report on this topic, and we submitted that in January. There's a link to it in our testimony. Interestingly, in that report, we didn't support the effort for psychologists prescribing as it was presented in the previous iterations of the bill. But we did acknowledge that with some modifications with respect to kind of the rigorous nature of the training and education, if that was increased, that the office would be supportive of that. So we think that as it's currently written, H237 really is a good example of the three-legged stool of qualification for licensure, which is how OPR ensures that public protection. And that three-legged stool is education, examination, and experience. So we think that the current proposal greatly improves upon the bill language as originally proposed. It includes a lot of the recommendations from our Sunrise report, and we testified on the House side of this earlier in the session, and we think that as it was passed by the House, it also incorporated some of our suggestions. We appreciated that. And one thing I did want to just mention, Senator Gulick, you talked about this being like one additional tool in the toolbox, and I really do think that's how OPR looks at it. We've also done an extensive study of mental health licensing in the state. That's been a 2-year study that our office has been engaged in terms of like the level of complexity in mental health licensing and how different licenses require different numbers of hours of training and education, and the pathways are so different, and this fits in nicely to those efforts of any tool that we can use to kind of increase access in the state. We're really in favor of, as long as it's safe for patients. So next year, you'll be seeing from the Office of Professional Regulation, we're going to be repealing and replacing all of our mental health profession statutes so that we can have some streamlining to make it easier for folks to get licensed while not sacrificing kind of competency and qualification. So just wanted to preview that a little bit. So you see in our testimony on page 2, we do have some additional revisions that we're requesting, and we've worked with Dr. Mark Barnett and the VPA as well as VMS, and we think that the language about the rotation and increasing the amount of time for the rotation is a measure that will be a more rigorous qualification, again, to that public protection piece. And then we also reduced the practice settings that the rotation should occur in from 9 to 5. And so you'll see that those practice settings that we suggest are psychiatry, geriatrics, family practice / internal medicine, emergency medicine, and neurology. So those were some changes that we would request. The other thing that still concerns us is the implementation timeline. So as the statute's written, I think the second effective date is currently July 1st, 2026. We are going to have to engage in rulemaking, and that will require a lot of stakeholder work. We'll be working with VMS and VPA and other stakeholders. So we're going to probably need more than a year for that effort. And because we are going to be repealing and replacing all of our mental health profession statutes, after we do that, we're going to have to do rulemaking in all of those professions.
Right.
And so psychology is going to be one of those professions. So we don't want to kind of duplicate that effort and do rulemaking and then do rulemaking again in another year or two. So we're hoping to push out the second effective date to January 1st, 2028. And I know this effort has been a long time in the making, but for administrative efficiency and for other things that we have going on in our office before then, we think this is a better timeline for us. Thank you. It's pretty interesting.
Senator Douglas and I have been talking a lot about mental health and how, what we need to focus on in the legislature. And I'm wondering, we can have this conversation another time if it's too big an issue, but the redoing the statutes around mental health, can you tell us what that would look like briefly?
Yeah, so we did a mental health licensing study and submitted that report in December of 2024. So you'll be able to see that. But basically, that was a 2-year study with tons of stakeholders and over, I think, 20 stakeholder meetings. And basically just looking at the complexity of all the different mental health licenses and trying to figure out how we can streamline the qualification and requirements to make it easier logistically for people to get licenses without sacrificing qualification and quality. That's right. So one of the major things that we're going to do is consolidate all of our mental health professions, with the exception of psychology, under one giant mental health board. Right now we have an allied mental health board, and then we have other mental health licenses, alcohol and drug counselors and social workers and others that are advisor professions. So they're not all under one board, and we think that's going to help us streamline things. We've also asked for an executive officer for mental health, and that's in this year's OPR bill. So that's someone who's going to be from a mental health profession who can help us with subject matter expertise in-house so that we can process applications more quickly, and they can help us with policy related things that we're doing. And also just, if you're looking to get a mental health license and you need to know how much supervised practice you need to have, you know, right now we've got, I think, 17 different mental health professions, if I'm remembering that correctly. And all of those are going to have different levels of how many supervised practice hours do you need? And what's your pathway? Do you need to have an education from really narrowly defined institutions, or is it broader than that? Can you supplement your education if you don't have exactly the right degree? All of those questions are things that we plan to address so that people can have greater access to the licensure, which will in turn provide greater access for patients, hopefully.
That's really exciting.
Yeah, it's very exciting. It's gonna be a lot of work.
Yeah, it's gonna be a lot of work, but it sounds like it's important and it's, you know, heading in the right direction. So,
Yes.
thank you so much. Any other questions? Great.
I wanted to say thank you to Sam for what he does, this mental health stuff up there. You do a great job up there. I don't do mental health stuff as much as I do substance abuse stuff. I'm a recovery coach, a family coach, a bereavement coach, emergency room coach, life coach. So I do a lot myself. I'm not certified on all of these. Only because, as you know, I lost my daughter to opiates. So therefore I couldn't save my daughter, but I could save somebody else. And Sam's saving people to he's a good man.
Thank you to both of you for the work you do. It's much appreciated. Yeah, and thanks again, Jen.
Thank you so much.
Yeah, really exciting. I think up next is Katie McLean to take us through the middle. Thank you, Katie. She's behind us. We keep having people behind us that we can't read. Same thing in my head.
Need a mirror.
Yeah, I know. And I don't know why this is on your desk, but I'm like, thank you so much. Sorry about that. I don't know how it's,
What am I
I don't know how we got there.
It's my agenda.
Okay, great. Katie, thank you so much for being here today.
You're welcome. Good morning. Here we go. Katie McLean, Office of Legislative Counsel. We have H 237 as passed house. So I know that we've already walked through this one time, but it was
A while
several months ago maybe at this point. So if I go into too much detail, you can tell me to pull back into a higher level. Section 1, I should start off by saying there's already an existing chapter in Title 26 on psychologists, and we're making some amendments in some sections of that chapter, including adding a whole new section specific to doctoral level prescribing psychologists. So first, in the definitions section, there are a few terms being added. Collaborating practitioner means a physician licensed to practice medicine pursuant to Chapter 22 or 33 of this title of the specialty in psychiatry. The DSM is the Diagnostic and Statistical Manual, mental health disorders, current at the time of practice. Drug has the same meaning as elsewhere in statute. Prescribing psychologist means a licensed doctoral level psychologist who has undergone specialized training, has passed an examination as determined by rule, and has received a current prescribing specialty under section 3019. That's the new section that's being added. That has not been revoked or suspended by the board. Prescription drug, again, cross-references existing law. In subdivision 17, prescriptive authority. This means the authority to prescribe or discontinue prescription drugs solely for the purpose of diagnosing, treating, or managing a condition recognized in the DSM. Prescriptive authority excludes authority to dispense, administer, and distribute prescription drugs and prescribe or discontinue prescription drugs for patients who are less than 18 years of age, over 80 years of age, or pregnant. And then at the top of page 3, powers and duties. This subsection A gives the board rulemaking authority, and this is being amended. Now they have the authority to explain complaint and appeal procedures to licensees, applicants, and the public. And that is struck. And what is added instead is authority to regulate prescribing psychologist licensees
including the settings of clinical rotations and prescriptive authority, including designation of conditions and drugs excluded from that authority, as well as requirements for the prescribing of particular drugs. And also regulate collaborative practice agreements, including collaborating practitioner qualifications and annual competency evaluations. Okay, that brings us to the top of page 4. And as I said, there is a new section specific to prescribing by doctoral level psychologists, and that's 3019. So in subsection A psychologist doctorate may apply to the board for prescribing psychologist specialty. The application shall be made in a manner approved by the board and include the payment of any required fees. In subsection B, specialty by examination, the psychologist doctorate shall be eligible for prescribing specialty if the psychologist doctorate holds a current license to practice psychology at the doctoral level in the state, has successfully completed a postdoctoral training program in psychopharmacology designated by the American Psychological Association or its successor, has completed clinical rotations over a total of not less than 14 months in not less than 9 practice settings, to include psychiatry, pediatrics, geriatrics, family medicine, internal medicine, emergency medicine, obstetrics and gynecology, surgery, and 1 elective. Has completed a national certifying exam as determined by rule, and meets all other requirements for obtaining a prescribing psychologist specialty as determined by rule. In subsection C, this is the criteria for prescribing medication. First, in subdivision 1, a written collaborative agreement is required for all prescribing psychologists practicing under a prescribing psychologist specialty issued pursuant to this section. The issuance of prescriptive authority by a collaborating practitioner to the prescribing psychologist shall only include prescription drugs for the treatment of mental health conditions that the collaborating practitioner generally provides to patients in the normal course of practice. The collaborating practitioner shall file the collaborative agreement with the board and notice of any termination of the agreement. Issuance of the prescribing authority for Schedule 2 through 5 controlled substances shall identify the specific controlled substance by brand name, generic name, and prescription or administration of a controlled substance by injection shall not be allowed. And then under specialty by endorsement, the director of the board may, upon payment for any required fee, grant a prescribing specialty without examination if the applicant holds an active psychologist prescribing authority in another U.S. or Canadian jurisdiction, and the requirements for psychologist prescribing authority in that jurisdiction are, in the judgment of the director, substantially equivalent to the requirements of this section. In terms of effective date, this section in section 2, which is the duties of the board, take effect first, July 1, 2025, and similar with what we were talking about yesterday, that gives an opportunity for rulemaking before the provision itself takes effect, and then the remaining sections take effect on July 1 of 26. Sorry, July 1 of 26.
That's the one that they want to push out.
They want it pushed out.
Yeah. Thank you, Katie.
You're welcome.
So a question about, I don't know why I stated it on telemedicine right now.
Good catch.
Thanks. But psychiatrists can see patients. What's the word I'm looking for? What's the verb or the adjective?
Virtually.
Virtually, thank you. They can see patients virtually. And they can prescribe medication virtually, correct? Psychiatrists do know.
I believe that's correct. I am not
Okay, I have to
that
look it up.
person who deals with telemedicine.
Okay, I was just wondering if
And Jen is the
prescribing
person you need.
psychologist, yeah. Yeah,
That's prescribing, they notify the pharmacy.
right. Yeah. Prescribe. Right. I'm just wondering if practicing psychologists would have the same. Okay, yeah, sounds like it, but we'll ask Jen.
She staffs telemedicine.
Okay, great. Thank you very much.
You're welcome.
Does anyone else have any questions for Katie? I will relinquish control of the committee and we'll hand it over to Chair Lyons.
Where are you?
Just
No, you're still in charge.
I think we can take a break because we have gone through everything that we needed to go through this morning. And
Wow.
we've got 10 minutes for our next
Wow.
witness.
Terrific.
Yeah.
Good work.
She doesn't
So